Good afternoon. So Kevin already talked to us, Kevin Plancher, today about AC joint, and hopefully I can convince you that this isn't necessarily a dismal operation with bad outcomes, and there may be some alternative techniques that perhaps you haven't seen or considered that may work in your hands. So I relabeled a little bit of the title of this talk to talk about not just reconstruction but repair. I think there's a difference here, and I'll get into that. No disclosures. So the first thing I would tell you is make sure you get the correct diagnosis. Make sure you determine the correct Rockwood grade. That's particularly important for identifying the type 4s. I think sometimes people can mistake these for type 3s when in fact they're buttonholes for the trapezius, and these won't get better. These are ones that need to be treated operatively, I believe. So first of all, how do you not image AC joint pathology? You don't get it supine. That's not physiological what's happening in the patient when they're upright. And as Kevin mentioned earlier, don't get weights in the patient's arms. They don't tolerate it, and if they can somehow tolerate it, they're going to lift their shoulders up, so you're going to get a non-physiologic view of what's going on at the AC joint. Lastly, on what not to do, don't image the AC joints individually, and don't try to meld them onto one radiograph. That's not an accurate way to determine the Rockwood grade. What you need to do is get a bilateral upright cassette radiograph and measure accurately the CC distance. This group here showed that. In addition, it was interesting in this paper, they also found that if the widening just on these AP cephalic tilt views, if there's widening at the AC joint, that suggests a type 4 injury. So I think that these are very helpful radiographs to get, and these are the radiographs you should be getting to get an accurate diagnosis. I think there's still definitely a role for an axillary view. So you can, again, try to identify those type 4s where you've got that posterior dislocation and an incarcerated distal clavicle. Physical examination, generally it's fairly obvious, particularly with the high grades. But for those type 3s versus type 4s, you're not sure, check to see if it's reducible. If it's not reducible, it's probably a type 4. And so what I do is I just push to see if it's reducible. Yes, it causes some pain in the patient, but at least you're getting an accurate diagnosis of what's going on there. So timing for repair, this is where it gets into should I repair it or should I do a reconstruction? Initially, I was sort of thinking 3 weeks is about all you got for a repair, and then beyond that, you should do a reconstruction. I've kind of moved a little bit further along the calendar, and now I will consider 6 weeks or possibly even longer. And in that case, I think you can take advantage of the body's repair process. And it's my belief the sooner that you can get to these, the better. Obviously, if you've got an in-season athlete, that's a discussion you're going to have. But the sooner, the better. More than 6 weeks, I think it's much more difficult to just do a reconstruction. I'm sorry, just to do a repair, and I think you need to consider a reconstruction at that point. Obviously, there's chronic changes. There may be a periosteal sleeve avulsion injury in a younger patient that's going to make a reduction more difficult. So I have a fair amount of experience in dealing with these in my time in the Army at Fort Bragg, taking care of special operations shoulders and 82nd Airborne soldiers. We saw a fair number of these, and one of the reports we put together was just sort of comparing all the different historical techniques, and we found that with the newer sort of suspensory button techniques, that although the outcomes in the study perhaps wasn't powered well enough to do this as a retrospective study, we found that using the suspensory techniques had much lower complication rates, much lower, and the grade afterwards was better. Now, admittedly, we were not using a lot of hook clavicle plates, and I was talking to Mike McKee earlier. He had a study earlier in the year that showed that can be a good technique, although there's potentially some problems with cutouts and things like that. But perhaps there might be some newer plates available in the horizon that may lower that risk. Now, I don't use arthroscopy for this. It takes too long to set up. If you got them in the beach chair position, you're fighting gravity. Furthermore, the head holder or the head can block your ability to accurately drill. And the imaging is just a huge hassle. You're taking a case that should be very straightforward, and you're adding a lot of complexity, cost, and time, and it's just not worth it, in my opinion. So forget the beach chair. Go supine. Quit using arthroscopy for these things. You'll have much better imaging. It's much easier for your tech. You can get that perfect view of the coracoid, and that'll avoid getting these aberrant drill tunnels where you're going to have a cutout of your sutures. You got to make sure you get that in the center of the base of the coracoid. If you miss, you're going to have a problem. Again, why fight gravity? Do it supine. The clavicle will reduce for you. I think the supine position is beneficial not only for AC joint, but for clavicle fractures in general, even proximal humerus fractures. We talk about infections. I exclude the axilla. I just tuck both arms. I put a little bump underneath the ipsilateral scapula, and there you go. That's all you need for exposure. So I like to call it the fingerscopic technique. So basically I use a small incision just underneath the coracoid, and then I use one over the distal clavicle, and I basically just finger dissect. My finger there, my index finger is right underneath the base of the coracoid. I use that to drill and ensure I know where my drill is going. I can image as well. And then on the top of the clavicle, then I have my access point to come down and make my clavicle drill holes. So here's just a case example. This is a 30-year-old special operations soldier with a type 3 AC joint. So again, I use a very small 2.4 millimeter drill bit. It's a cannulated drill bit. It lowers the risk, I think, of a clavicle fracture that's been reported. So I try to use a real small drill bit. After drilling, I then pass the nitinol wire down through the coracoid base and pull it out the front, and I use it as a shuttling suture. I drill a second hole, more medial. And then basically the implants are very simple: 3 titanium buttons, a self-tensioning suture loop, and a non-absorbable suture tape. Very strong suture. And then obviously if I'm doing a reconstruction, which I'll talk about in a second, I'll use a semitendinosus graft and preferably a autograft. So after you put that together, what I'll do is I'll then feed it up inferiorly, and both sutures will fit through that 2.4 millimeter drill bit, even the tape suture. I pull it up into position, and I will pass both through the lateral tunnel, and then I'll shuttle the other one medially through the other tunnel. I'll make a small little incision over the anterior deltoid to then pass that through, and then as you can see, I'll shuttle that through the most medial tunnel. And then I'll use the loop to dial in the tension, and I like to over-reduce these. As we found in our results when I was at Fort Bragg, they all come up. So if you over-reduce it, some of the laxity in the system will work its way out, and I've never had a problem with over-reduction of these things. I'm not crazy aggressive with it, but I will over-reduce, and I try to actually achieve that. I use a ball spike pusher to hold it down with my surgical assistant, and then I'll tie these. For me, this has turned into a very straightforward 30-minute operation, even with residents, and my results have been much better, including my lack of complications. Now, reconstructions, as I mentioned, if you've got a more chronic, high-grade injury, I'm not sure that just the suture button techniques will work individually. I think you probably do need a graft to do this. And so I prefer to use autograft. I'm an autograft person really regardless of whatever surgery I'm doing. And so my AC joint reconstruction is no different. I think if you keep them supine, it's very easy to get down to the knee and harvest the graft at the beginning of the operation and get that prepared while you're doing your surgery. So the semitendinosus graft, I'll pass underneath the coracoid, and you obviously have to take down a little bit more of the anterior deltoid to do that. There's a passing device that comes in one of the sets from one of the companies that makes this. You can also use a Latinsky, and there's some other creative ways that you can pass this around. And then I'll fix it with cannulated headless screws. And the nice thing about that is you still need to back this up with fixation. And so I'll use still the looped tape as well, and you can use that cannulated screw to pass another suture through in a button to back this up. And so again, you still drill with a small 2.4 millimeter drill bit, transcoracoid drill tunnel. You've got your 2 tunnels just like before, except you make them larger. You fix them with your headless screws, and then you back it up with your self-tensioning loop and heavy suture. And don't forget to add the AC ligament reconstruction. I think this is an important thing to add. Obviously, you have to make your incision a little bit longer, but it's not that hard to do. And so you generally have a lot more graft left over with your semitendinosus, and I route it through the coracoid and then back onto itself. And I think that this, especially for high-grade ones, this is an important step that you should add. We know that the AC joint is responsible for anterior to posterior translation, and this helps to decrease some of that motion that can occur. And again, even in these cases, I try to over-reduce the clavicle because we know they're all going to come up a little bit. So my post-operative protocol for these things, they all get immobilized for 8 weeks. For the repairs, basically I let them go at 12 weeks. Generally at that point in time, the healing process has already occurred. I don't do physical therapy with either group, as Kevin mentioned. Sending him to the therapist will just add stress to your construct, and so I don't do that. And then for the reconstructions, I'll delay them to get back to sports for probably about 6 months to try to let that to heal. Thank you.